So, welcome to the TRT and Hormone Optimization YouTube channel. And as a guest today from the UK is Felix Hay. Welcome, Felix.
Hi, Dr. Devos. Thank you very much for having me on.
It's a pleasure. So, let's cover some different topics today. But before we start, talk a little bit about yourself.
Cool. So, hi, everyone. My name's Felix, as Dr. Devos said. I'm an advanced clinical practitioner by background. Bulk of my experience is in emergency medicine in the UK, working for the National Health Service. And a few years back, I diversified and undertook some training in hormone replacement therapy, predominantly male hormone replacement therapy, so TRT at the beginning. But I've recently undertaken formalized training in female HRT as well. So I now work in a clinic of my own alongside Dr. Babar, who's the medical director at Healand Clinic in Leicester in the UK. And we provide TRT and HRT to men and women, as well as a few other services like psychotherapy, pain management, bioenhancements as well. So you can check out all our services at healand.co.uk.
Awesome. Incredible introduction. Thank you, Felix. So, as a first topic, let's cover the different forms of or types of hypogonadism.
Yeah. So testosterone deficiency, or sometimes referred to as hypogonadism by us clinicians. You've got sort of four main types. You've got primary, secondary, tertiary, and then functional. So your primary hypogonadism is usually where there's a problem with the testicles themselves. Now, that might be secondary to chronic infection, genetic disorders, structural deformities like varicoceles or tumors. It might even be the absence of your testicles. You might have had an orchidectomy or had a testicle removed secondary to cancer, and that leaves you deficient. You can have one that's a little bit rarer, but people don't often think about, is damage through surgery. So a lot of guys might get a vasectomy as they get older, and that can actually have an impact on our testicular function, and that would come under primary as well. So it's not without its risks having what we think are simple procedures like that. Secondary, you're looking at a problem with the signaling process between the brain and the testicles themselves. So the pituitary gland, or the anterior pituitary more specifically, is the powerhouse that sends down our chemical messages. So luteinizing hormone, follicle stimulating hormone. And if there's a disruption in the amount of those or the way that those get to our testicles, that can cause us to have decreased levels. So that's your secondary deficiency. Tertiary is a little bit rarer. That's where you have a hypothalamic problem, and that's where there's no sort of GnRH or gonadotropin releasing hormone getting to the pituitary, and that can cause issues with other hormones like prolactin. So you can start having rising prolactin, and that can push your testosterone down. You can also, in that category, get small tumors called microadenomas, or sometimes known as prolactinomas, that shoot your prolactin up, and that pushes your testosterone down. And then finally, you've got functional. And I think that's probably, in my practice, probably one of the more common areas that I see. Accounts to between sort of 30 to 40% of patients that I see. And that's where it's specific lifestyle factors. So, human beings, we like to burn the candle at both ends. We like to experiment. So you've got things like calcium channel blocker drugs, so more commonly known as cocaine. You've got amphetamines, so speeds that can interfere with our hypothalamic pituitary gonadal axis, which is what governs all of our hormone production. And then you've got sort of recreational abuse of steroids, so androgenic anabolic steroids specifically, that will sometimes cause suppression of our HPG axis that, if not handled carefully after you've been experimenting with those types of drugs, can fail to reactivate again. And that link between the brain and the testicles is broken.
Mm-hmm. And how do you go about searching the exact type? What is the cause? If men present with low T symptoms, how do you find out the type?
Yeah, so it's like anything in medicine, really. So you're going to be doing a combination of looking at a good history and physical examination, and then correlating that with their symptoms that the patient reports, and then using quantitative biomarkers, so blood testing. And blood testing is an interesting one because we'll probably get onto it in a bit about reference ranges and stuff like that, and exactly how useful they are. But I'm a big advocate of listening to the patient. So when you're taking your history, you really need to listen to these men and women about the symptoms that they're experiencing, because it's the quality of life that deficiency in hormones or dysregulation in hormones has that impact on patients. And that really is why they come and seek us out. Because I don't know what it's like in Belgium, but in the UK, if you try to approach an NHS doctor, like a primary care physician, telling them about your qualitative symptoms. And the common ones with testosterone deficiency will be reduced libido, reduced energy levels, so increasing fatigue, falling asleep in the afternoon when you wouldn't normally, at a young age as well. We're not talking about 90-year-old guys here. We're talking about guys in their mid to late 30s and early 40s. And then you've got erectile dysfunction is a big one as well. And this overall feeling of loss of sense of self, and some people call that depersonalization, that sort of brain fog. You're not quite who you feel like you used to be. So I think those are your main sort of qualitative symptoms that we tend to see reported a lot. And then, of course, with anything, there's going to be governing bodies, and in the UK, that's the British Society for Sexual Medicine, and I know they have a European branch as well. And they sort of set out the criteria that are they're guidelines, and I think that's important to point out, is guidelines. Like they're not rules, like they are guidance. So I think as a clinician, we need to remember that we can make decisions based along guidance and use our clinical experience as well. We don't need to be told what to do. But having said that, they've got these arbitrary numbers, which are exceptionally low. And they recently revised them, and you have to have a total testosterone level of 12 nanomoles per liter or below to be considered for a trial of TRT, and or a free testosterone level of 0.220 nanomoles per liter to be considered for a trial. And then an outright sort of hard deck of a number, if you will, to say this man needs TRT is 0.118 for your free testosterone, which is it's absolutely shocking. And I think that I have sort of certain theories about why that is. And it comes down to how we test our normal or average reference ranges. And that's because the society, and I think this is the same across the world. I hope I'm not speaking out of turn. I'm not trying to insult any other countries, but we are getting sicker and sicker as a society. And that is primarily due to rising comorbidities, with the most obvious one being obesity. Now, obesity obviously comes with its own issues and can actually be a cause for testosterone deficiency, because of the fact that the more fat cells you have in your body, then the more substrate material you have for the enzyme aromatase. Now, as we all know, aromatase will convert our testosterone into estradiol and other estrogens like estrone and estriol. Now, if you have more of that in your body skewed against your lean muscle mass, then you are going to convert any testosterone that you do make into estrogen. And that will mean that if you're testing these guys to get your average range for the UK, then we are basing our references on a sick society or a sick sample. So that then leaves people that aren't obese being underserved because they can't be diagnosed, because the range is so low, because it's based on these sick people. So it's an interesting one, like when you think about trying to diagnose something, because we're a little bit sort of hands tied by the guidance. But like I said, I'm a big advocate of listening to patients' qualitative symptoms and how they're feeling, whether it's affecting their life, and then we look at the numbers as well. But with private practice, we have the luxury of being able to treat people on a case-by-case basis, and we're not bound by like in the NHS, where you go see a GP and they say, oh, that's it, you don't reach the exact number that it says, so you're done, you can't have anything. And these poor guys, it leads to suicide in some cases, and it's just absolutely heartbreaking to think about that, when if you could just balance their hormones a bit for them, they could function normally.
Yeah, same thing here in Belgium. Most GPs, if you contact them, they would measure the testosterone in your blood just because you ask it, and they will say, well, you're still in the reference range, except you're getting older, man. And that's about it.
Yeah. Deal with it. Yeah. It's just, and that's the other thing that's interesting, isn't it, Dr. Devos? They just test total testosterone, which gives you no information whatsoever, without, at the very least, your SHBG, your estrogen, you can't look at what's going on. There's no understanding of the conversion using 5-alpha reductase into DHT, and then using the aromatase enzyme and converting to estradiol and looking at that balance. And they very rarely measure SHBG to see how much of your testosterone is bound up. And you can't calculate a free testosterone without the albumin in the SHBG. And exactly. And I think they do that on, and not on purpose, out of being unkind. I would never want to cast aspersions on my colleagues, but I think it's because it's workload management. The guidance says test this, so they just do that. And rather than look into it a bit more and see that it is very nuanced and very complex. and they could be helping guys a lot more. But it's just one of those things, and I think they're overworked and under resourced. So I do feel a bit for the primary care colleagues that I have, but we can definitely do better for us men out there.
Sure thing. Thanks for explaining, Felix.
No worries.
Check out my TRT workout split or the ebook The Ultimate Guide to TRT Cream. Links to the merchandise shop in the description.